So here we are at London Valves. The atmosphere is still buzzing, the main arena is full. There's a huge amount going on, and a lot of discussion is focusing on new indications for intervention in aortic stenosis, which have been triggered by the new ESC EACTS guidelines. It's a great pleasure, of course, therefore, to be here with Fabien Praz, who co-led the guidelines document with Michael Borger. Fabien, summarize for us maybe the three key outcomes of the guideline recommendations in relation to AS.
So thank you very much, Bernard. Of course, you were also part of the task force, so it's a conversation which I'm very happy to have with you. So we have three main changes for aortic stenosis and TAVI in particular. So we have an expansion of the indication to younger patients that are age 70 and more, which was 75 before. We have a new recommendation that open the treatment, the early treatment of asymptomatic aortic stenosis. And we have also some new consideration for bicuspid patients.
Okay, so let's start with perhaps one of the most controversial discussions, the expansion of indications and the lowering of the age threshold. How is that impacting on practice in your hospital?
So obviously what we wanted to do in compared to 2021 was to do an adjustment regarding the evidence that we have. And the patients that have been included in the randomized control trial obviously are characterized by something very specific, which is their age. And this category of patient, because the results have been good also inside of different categories of risk, and these patients, they are characterized by an age of 70 and more, and we have evidence on these patients. That was the adjustment, and I think this will impact practice because more patients will be considered for TAVI, but we will have to think more also about lifetime management. And age is a very important factor, but not the only one. So we will look, and we encourage this in the document, to look more at anatomy, comorbidities, but also the option for future intervention if they are needed, starting with surgery in some patients, or having TAVI for all patients age 70 and more, but looking already at the option of a second valve in 10 years or maybe 15 years, because these patients live longer and longer.
And of course, we've had some reassurance for that position by the 7-year outcomes of Partner 3, presented at TCT, but also amplified here in London in a special session that we co-hosted with our colleagues from the US, focusing on this very encouraging durability data.
Absolutely. And Bernard, you know a lot about aortic stenosis, and one of your interests is also asymptomatic aortic stenosis. So I mentioned we have this new 2A recommendation for asymptomatic patient that is quite wide in terms of indication. How will that change your view and your conversation with these patients?
Well, of course, all this change was stimulated by the outcome of early TAVR and other supportive evidence from surgical trials. So again, it's strongly rooted in evidence. It's important to emphasize that. I think the implication for practice is that we need to be connecting with our referral networks so that aortic stenosis is identified early. It is characterized and diagnosed accurately using advanced echocardiography. And patients in whom intervention is feasible should be allowed access to a heart valve center at a very early stage. And then discussions can take place with the patient about the pros and cons of early intervention. The workup can be done in anticipation of a TAVI procedure, so the patient is ready to go. And then it can be a shared decision regarding whether to intervene early or whether some patients prefer to wait and see, knowing that they are under the care of the right specialist and they're ready to go with their procedure. So I think that's how it will impact and roll out in the UK. And I'm sure it will be the same in many other countries.
I think you said the right word, and the very important one: conversation with the patient, shared decision, and then looking also at lifetime management regarding the strategy.
Exactly. And finally, Fabien, let's just focus on the subpopulation with bicuspid valve disease, bicuspid aortic stenosis. Some uncertainty about the outcomes, for example, in the Notion 2 trial. Again, do we need to treat these patients as a special subset?
Yeah, that was the feeling a little bit of the task force, looking at the data. That was a very small group in Notion showing that the outcome was a bit less good or less convincing with TAVI, but this is a very small population of patients. And you have observational data showing that the TAVI can be also very safe in this patient. So we have a TAVI recommendation specifically for bicuspid. So we make the difference in terms of mechanism, which I think made a lot of sense between tricuspid and bicuspid, because tricuspid patients have been included into randomized controlled trial, and we have very good evidence there that TAVI is at least non-inferior to surgery. For bicuspid, it looks a little bit different. There are some risk of doing TAVI if the anatomy is not perfect in terms of residual regurgitation or maybe misplacement of the valve, and we need to know more, to learn more, and there will be specific randomized controlled trial in the future looking at this question and giving more evidence for this specific subset of patients.
Exactly, and meanwhile we need to remember that minimally invasive surgical aortic valve replacement is a very good option for these patients. And meanwhile we have to be a patient community for these new randomized controlled trials ongoing to yield the evidence that we need to guide our future practice.
So Bernard, I think in summary, very good news for our patient with less invasive treatment, with an indication for TAVI that is now also in the guideline, one indication for younger patients, irrespective of the surgical risk, as a first-line therapy if the anatomy is good, if the patient is suitable, and I think a lot of new evidence to come for a specific subset of patients.
Exactly. Evidence-supported guideline recommendations influencing practice. Thanks very much for joining us.